Huh?
Sucker is good? Yeah. That's good. So today, inshallah, we'll discuss about the non-neoplastic disease of the thyroid gland. What are the different thyroid diseases? First of all, you should know about the thyrotoxicosis. What is thyrotoxicosis? Thyrotoxicosis is a hypermetabolic state due to increased thyroid hormone. Hypermetabolic state. Okay? Regardless of the cause. Regardless of the cause. It is a hypermetabolic state characterized by increased thyroid hormones. It may be because of the thyroid gland hyperfunction or maybe some other cause. Okay? So thyrotoxicosis with hyperthyroidism. So it means something wrong with the thyroid gland itself. It can be primarily with the thyroid gland like hyperplasia, adenoma, and like goiter also. Okay? Or it can be secondary. There is pituitary adenoma, it causes increased stimulation of the thyroid gland. There is hyperplasia of the thyroid gland. It leads to thyrotoxicosis. So thyrotoxicosis, yeah, we will come to that. Then thyrotoxicosis without hyperthyroidism. Okay, without hyperthyroidism means the thyroid gland is not activated yet. I will explain. It can happen in various forms of thyroiditis, like granulomatous and lymphocytic thyroiditis, stuma ovary, and there is ectopic thyroid tissue in the ovaries, or due to increased thyroid intake, thyroxine intake. I know this is confusing. Yes, one reason. Hyperthyroidism means hyperfunctioning of the thyroid gland. Class. Hyperfunctioning.
Not same meaning?
Yeah. Hyperthyroidism means hyperfunctioning of the thyroid gland. It is functioning highly or effectively or in an increased manner. Okay? Thyroid gland. But thyrotoxicosis means it is a hypermetabolic state characterized by increased in the T3, T4. Okay? Maybe due to hyperthyroidism, maybe due to any other cause. Clear? So thyrotoxicosis is a broad term. It includes hyperthyroidism. But the most common cause of thyrotoxicosis is hyperthyroidism. Is the increased functioning of the thyroid gland. Most common cause. Yeah. It is in this. I will define. Don't worry. It will go. Yes.
So when thyroid hormones I was treated.
Okay.
This edge go down.
Yeah. Look, everything will be explained with each disease. Feedback loop, as you are talking about, we will explain that with each disease. Because it will be different in different diseases. Okay? It will be different in different diseases. Sometimes TSH can decrease, sometimes it can increase also. This is how you will differentiate between the different diseases. Okay? How you will differentiate. Now, this is the hypermetabolic state and hyperthyroidism. Hyperfunction of the thyroid gland. Second is hypothyroidism. Decreased functioning of the thyroid gland. It can be primary. Something wrong with the gland like post-ablative. You do some surgery, a part of the gland is gone, you give radioactive iodine, then again damage to the gland occurs, you give radiotherapy, damage to the gland, and it causes hypothyroidism. Hashimoto thyroiditis because damage to the follicles, again hypothyroidism. Iodine deficiency, it can be congenital due to enzymatic defects. Some drugs can also cause. Secondary due to hypopistolism. Okay. So these both primary, secondary, here primary, secondary. Then different types of thyroiditis we will discuss. Goiter, diffuse multinodular, neoplasms, adenoma, carcinoma, and there are congenital cysts like thyroglossal cyst and duct. Now we will be going back. This is the normal appearance of the thyroid gland. Okay, follicles lined by cuboidal or low columnar epithelium and filled with the pollen. Now this is thyrotoxicosis. It is a hypermetabolic state characterized by elevated circulating levels of free D3 and D4. Okay. Most commonly caused by hyperfunction of the thyroid gland. Most commonly caused by hyperthyroidism. So thyrotoxicosis, broad term, most common cause hyperthyroidism. Okay, of thyrotoxicosis. So etiology: Graves' disease or diffuse thyroid hyperplasia. This is hyperfunction of the thyroid gland. Second, from outside. First, we will discuss inside the thyroid gland, like Graves' disease, diffuse thyroid hyperplasia. Second is hyperfunctional multinodular goiter. Then the adenoma. Okay, hyperplasia, goiter, and adenoma. These are within the thyroid gland. Okay. Now the exogenous causes outside, like exogenous thyroid hormone ingestion. Somebody is taking thyroxine. Then some thyroiditis also can lead to hyperthyroidism. Okay, because of the release of the hormone. DSH secreting pituitary adenoma. This is again from outside. Outside, not outside the body, but outside the thyroid. Okay? And the ectopic thyroid. Sometimes the thyroid tissue is present, but outside the thyroid gland. Outside. It can be in the ovary also. The females. It can be anywhere along this track. How the thyroid is formed. So it can be present. So ectopic thyroid tissue will also give rise to a hypermetabolic state. So this is thyrotoxicosis. These are the causes. Primary, wrong with the thyroid gland itself, and secondary maybe pituitary or maybe ectopic thyroid tissue or maybe exogenous hormone administration. Clear? Now, what will be the signs and symptoms once a person is having increased thyroid? What is the function of the thyroid hormone? You give me question and question, I will also ask.
Growth and development.
So the main function of the thyroid hormone is metabolism.
Metabolism.
So what it causes to the metabolism?
Increase.
It increases all aspects. Basically, it causes catabolism of the carbohydrates, catabolism of the fats, and causes increased protein synthesis. So increases the metabolism. Okay, this is the whole thing. How it causes it? Anybody? How it causes? How it causes increase in the catabolism? I mean the mechanism. We know it causes, catabolism of the fat, catabolism of the carbohydrate. Yeah. How? Yeah.
TPNT4 bind to payroll, lithium receptor. Then you have concept complex. Binds to payroll, hormone, response element, RA. Then transcription.
Basically, they are acting on the genes, isn't it? They are causing increased transcription of the genes. Like he said, how it will do, thyroid hormone response elements are there. So basically, and what is the most important hormone? D3 or D4? D3 is most important, okay? But which hormone is more formed by the thyroid? D4. And then in the periphery, it is converted again back into D3 and D4. So you have the good knowledge about the physiology. Very good. So then we will now go to the clinical features. What it will cause? If you go one by one. Hypermobility of the GIT tract. Now hyperthyroidism means hyperfunction of the thyroid gland due to hyperplasia, due to Graves' disease, or due to adenomas. Okay. Hypermobility of the GIT tract. What will happen if there is hypermobility? Diarrhea can happen. Then in the CNS there will be nervousness, irritability, anxiety will be there. Okay? Then tremor, hypermetabolic state, tremor will be there. Palpitations, tachycardia. Even the person can go because of the increased rate, he can go into congestive heart failure also. Congestive heart failure. Then in the eyes, prominent. Yeah. So wide staring gaze will be there. This is due to sympathetic overstimulation. Catecholamines are more. Okay? Sympathetic overstimulation. Then proptosis can be seen. This is seen in Graves' disease only. Wide staring gaze can be like this. Okay? But proptosis means even the eyeball is protruding out. So this will be in Graves' disease. Normally also they will have, wide staring gaze, eyes will be big, but protrusion will be seen only in Graves' disease. Protrusion or exophthalmos we call it. Eyeballs will protrude out. So the skin again will be, vasodilation will be there. It will be warm, flushed and soft. Then because of vasodilation there will be excessive sweating because the person wants to lose the heat which it is producing. Then heat intolerance because of this. Already the more heat is being produced, so he will not tolerate the heat. Weight loss will be there because it is catabolic, but there will be increased appetite also. Because but there will be weight loss. Weight loss will be there.
For example,
What do you think the difference is? Tachycardia and palpitation.
publication is very relevant and person can be aware
Very good. So tachycardia is the increased heart rate. He may be aware or may not be aware. But palpitation is the aware. Sometimes you get
Feeling, Victor, feeling heart
can
rate.
feel, yeah. Tachycardia normally also you will get. You will, running and you will get the tachycardia. You will not feel, but palpitation you will feel. You will feel and you will be afraid. Now, these are the signs and symptoms which will be there. Other signs and symptoms you can see here. Hair loss can be there, lid lag, lid retraction can be there, wide staring. So if he moves the eye, lid will not move. It will,
lid lag.
This is lid lag. It will not move fast. It will be slow to move. And retraction means it goes back, retracted. Tachycardia, palpitation, other things, even I cannot see. Microtachy is there, thickened skin will be there, onycholysis, destruction of the nails.
Regular.
Yeah, cranial myxedema is there, proximal myopathy, pain in the muscles will be there, osteoporosis, bones, how the bones will be affected by thyroid hormone. It causes increased osteoplastic resorption. So osteoporosis will be there. So basically catabolism. It will increase the catabolism in the body. Clear or not? We can stop here.
No.
If you want to ask. So hypothyroidism or myxedema. This is decreased functioning of the thyroid gland. Okay. Many times I can miss also because I don't look at the slides too much. So what is thyroid storm? Abrupt elevation of the acute, severe or abrupt elevation of the thyroid hormone. Okay. So acute, abrupt onset of severe hyperthyroidism, mostly it will be seen in the Graves' disease. And what is this basically? Thyroid hormones will be elevated, they will cause more sympathetic stimulation and there will be more catecholamines. And this is a medical emergency. And it will occur in a Graves' disease patient during periods of stress, like infections are there. There is some surgery, there is trauma. Okay. So if you don't treat this thyroid storm, the patient can die because of this. Okay. So this is a medical emergency. And one is apathetic hyperthyroidism, in which in elderly or people who are having diabetes and other things, comorbidities, many diseases together, especially in elderly, they have hyperthyroidism, but the things are blunted. They have thyroid hormone excess, but all the features of thyroid hormone excess may not be there, blunted. Like in diabetes, you have autonomic neuropathy, isn't it? So sometimes, even if there is hypoglycemia, the features will be blunted. Sometimes the diabetic patients have MI, but this is a silent MI because autonomic blunting is there. Yeah, I am saying the features will not be there. All the features of, like in young patients, all the features will be there. But here, all the features of thyroid hormone excess will not be there. So that is why it is known as apathetic hyperthyroidism. So it can be misdiagnosed in elderly, especially in elderly. So this is hyperthyroidism. Cause is hyperthyroidism. But if it occurs in elderly, all the symptoms which you see in the young patients will not be present in the older patients. Again, many diseases are there. Suppose there is diabetes. So there will be autonomic neuropathy. So autonomic nervous system is not working properly. So the symptoms again will be less. Thyroid stop, the thyroid hormones will increase as well as the catecholamines. All these things, sympathetic overstimulation will be there, and there will be severe. This is very severe. Why the patient will die basically? When there is acute increase in the thyroid hormones along with acute increase in the catecholamines, the heart is put under so much pressure. There is severe tachycardia, severe arrhythmias, and many of the patients will die of the arrhythmias. Okay, so we need to control it. Okay, the thyroid hormones as well as the catecholamines will increase, and they will put the pressure on the heart. And the most common cause of death in this thyroid storm is cardiac arrhythmias. Arrhythmias, atrial fibrillation, ventricular fibrillation. All the heart muscles, they will be, one is contracted, another, there is no synchronization in the contraction. Fibrillation means there is no synchronization. When there is no synchronization, you know what will happen. It should be synchronized. If there is no synchronization, the patient can die because the heart will not pump the blood. So these are the things in the thyroid. There. This is confusing, not only for you, but for us also. Because many diseases are there, and our labs have. But inshallah, if you go home, it will be clear. One, you have to read it. Study once hypothyroidism or mixing. What is hypothyroidism? Hypofunctioning of the thyroid. Okay, but it can be primary or secondary. Primary, after surgery, Hashimoto thyroid restriction in the thyroid gland, iodine deficiency. As you know, iodine is required for the formation of the thyroid hormone, and many drugs are there. Now, what will happen to the T3 and T4 levels?
Decrease.
They will be decreased. It will lead to decrease in the metabolic rate, and there will be increased mucopolysaccharide accumulation in the dermal connective tissue. Okay, this is why this is called myxedema. Okay, mucopolysaccharide, mucopolysaccharide accumulation leading to edema in the body. So person, yeah. But if you press it, it will not go down. There will not be pitting. You see in cardiac edema what happens? If you do it like this, here, it will pit. Okay? But this type of edema will not. This is how you can differentiate it from the congestive heart failure or cardiac edema, and this. This is different. Edema due to hypothyroidism will not pit. This is known as non-pitting edema. Okay? Or myxedema. Myxi means, as you know, mucopolysaccharide accumulation leading to the edema. And why it is known as myxedema now? It is clear. So hypothyroidism can lead to myxedema. But myxedema in the adults. Myxedema we use mostly for the adults. What do we use for the children? Cretinism. Okay. No, I am fond of one thing like the birds. Because last time you asked me. So why the name cretinism is there? So we will be concentrating a little on the words also. Cretinism.
Creation. Maybe from the word creation.
It is derived from cretin, basically cretin. Cretin means creation or creative. It is a French word which means Christ. Christ. You know Christ?
Yeah.
they say Christ. Huh? So Christ, why they say Christ? Because the child is so much sluggish, so much mentally deprived that he will not do any sin. He will not do any sin. It is basically regarding the sin. He doesn't have the mental capability to do any sin. So they call him cretin. Like in Christ. Sinless, innocent, like that. Not on the basis of the intelligence, but he is deprived because of the mental sluggishness to do anything. So cretin is derived from the word Christ. Okay. So this is called cretinism in children. So decreased T3, T4 level, decreased metabolic rate, increased mucopolysaccharide accumulation inside the dermal connective tissues. And these are the causes, and it can be pituitary failure also, the secondary cause. Yeah, post-ablative means after the surgery, there is some surgery of the thyroid gland, or after the radioactive, you give the radiotherapy, you give radioiodine to the patient, this will cause ablation, destruction of the thyroid. Okay, you are saying it because of feedback loop, there will be hyperplasia and other things. We are saying post-ablative, after the surgery, not during the surgery. Post-ablative, after the post-operative, post-operative, okay, post-radiotherapy, post-chemotherapy, like this. After this, so these are the causes. What are the clinical features now? And what is myxedema? Myxedema is also known as Bull's disease. Gull disease or Bull's disease, whatever you call it. GULL. Named after the physician who first described GULL. Gull's disease. So cretinism is there, myxedema is there, or Gull's disease is there. So cretinism mostly seen in children and infants. So there will be the most common cause is dietary insufficiency of iodine, and the other causes are metabolism defects, inborn errors of metabolism. And what will happen? Thyroid hormone in children is responsible for skeletal development and CNS development. It's very important for you. So there will be impairment of the skeletal development as well as the CNS development. The patient will remain like this. What is this? Can anybody read? Dry hair, slowed mental capabilities, then loss of eyelids or eyebrows. You can read, or I am growing old. Anybody can read? Muscle weakness, muscle wasting will be there. Coarse facial features. Facial features will be coarse, big face, tongue will be big, it will be protruding out. All these features, sluggish, and many things are there. I think something wrong with ECG changes, bradycardia will be there. Every organ will be affected. So thyroid hormones will be less, so everything will be slowed down. Like in hyperthyroidism, everything will be increased. So here everything will be slowed down. What are the various symptoms and signs? Apathy, listlessness, mental sluggishness, okay, cold intolerance. Here it was heat intolerance, here he will not be able to tolerate the cold. Often obese because of accumulation of the mucopolysaccharides. In the skin, there will be non-pitting edema, tongue will be enlarged. Again, bowel movements, there increased, where it will be decreased. So constipation will be there. And cardiomegaly and pericardial effusions, again due to mucopolysaccharide accumulation in the connective tissue. So diagnosis: decreased T4 T3, which will lead to increase in the TSH. Okay, this is the primary lesion within the thyroid gland itself. But if there is hypothalamic or pituitary failure, there will be increase in the TSH. So you have to see yourself. This is how it will happen. Normally you will find mostly this. If there is something wrong in the thyroid gland, decrease T4 T3 leading to compensatory increase in the TSH. But if there is hypothalamic or pituitary failure, again the TSH will also be decreased. This will also be decreased. So this is why the doctor will order all the investigation, T3, T4 and TSH. So you have to see what is the exact disease, whether one is increased, the other one is decreased, whether both are increased, whether both are decreased. So this is about the mixed edema. Huh? I don't understand. Slow mental capability. Sluggish means slow. He is slow. His capabilities are slow. Suppose I will give you a maths question. You will solve it in 5 minutes. He will take 15 minutes. Slow capabilities. Sluggish. So now the goiter. How many goiters you have? So one is called colloid goiter, another is parenchymatous, another is multinodular. When the goiter will happen, suppose it is occurring, let's understand. There is decrease in the iodine. Okay. What will happen next?
Decrease synthesis.
Decrease in iodine will lead to decrease synthesis of the thyroid hormone. What it will cause?
Decrease secretion.
Increase in the
TSH.
What TSH will cause?
Stimulation of the thyroid.
Stimulation of the thyroid. So what will happen? Parenchymatous goiter. Okay. TSH is being it is being secreted in increasing amounts. What will happen? There will be hyperplasia of the thyroid epithelium to compensate for decreasing quantities of the thyroxine. So hyperplasia of the thyroid epithelium because of the store colloid. So everything is being used up, okay, to form increased quantities of thyroid hormone. So less active areas will appear later, compressed by the hyper. So when you say parenchymatous goiter, you will find mostly the hyperplastic areas because of increased TSH. Okay. So two types are there. One is colloid goiter, another is parenchymatous. Parenchymatous means parenchyma. So increased parenchyma in the thyroid gland. Sort of hyperplasia. Just like Graves' disease. There is both. But here TSH is increased because of this it is increasing. Second, the colloid goiter. Here you will not find any epithelial hyperplasia. What will happen? Follicles will accumulate large amounts of collagen. Okay? They can break and coalesce with each other forming big cysts, as happens in the goiter. And areas of hemorrhage, fibrosis, dystrophic calcification may be there, and it can be diffuse or multinodular. And rapid enlargement can lead to hemorrhage or tracheal compression and striding. Now, what do you mean by this? It means there are two phases. How the goiter occurs. We will go to the next slide. It means there are two stages. One is the hyperplastic stage, another is the colloid involution stage. So, colloid involution and hyperplastic. So, sometimes first there will be hyperplasia of the gland, followed by colloid involution. So, you will find only these are the two stages and recurrent episodes.
There is no
In colloid, yeah. Here. This is about the stages of the colloid. Stages. It occurs in stages. Diffuse, first of all, it will be diffuse. Okay. So diffuse can be parenchymatous followed by colloid. Okay. Then the multinodular. Parenchymatous, colloid, multinodular. So it is occurring in stages. Okay. Stages are there.
There are stage we have to this.
Yeah.
In the colloid we know how to do.
Yeah. So go back to this one. Over here. Yeah. So multinodular goiter, what will happen? If there is damage to the epithelium, colloid is being, the colloid follicles break. So there will be inflammatory reaction followed by the fibrosis. Okay. So this fibrosis will cause, it will form tracts and it will form nodules, which will separate the hyperplastic areas with the less active or the colloid area. Hyperplastic and less active or the colloid area. So multiple nodules will be formed. This is long term. When the things start first of all, there will be hyperplasia of the gland. So parenchymatous goiter, enlargement of the gland because it is trying to compensate. But in between there will be colloid involution. Colloid will be more, so colloid goiter will happen. Then the recurrent episodes of hyperplasia and colloid involution will lead to multinodular goiter. So in this multinodular you will find both hyperplastic areas as well as the colloid areas. Clear? Hyperplastic as well as the colloid areas. So how it occurs? It will become clear, no problem. It will lack of iodine, most common cause, okay, lack of iodine. Second is defect in the enzymes, which are responsible for the synthesis of T3 and T4. Then hypercalcemia can also interfere with the hormone production, okay. And there are many drugs like sulfonylureas, lithium, amidorone, and resorcinol, and there are many vegetables which belong to the cruciferous family, like cabbage is there, cauliflower is there, turnips are there, cassava is there. Yeah, that you see, from the net. What are these? Cabbage, turnips, cauliflower, Cabbage, If in India, I will tell you a joke. If in India, Muslim women are there, many of them, will do, hijab. Many of them will not do. And when a person is in hijab, especially female, Indian boys, teasing and other things are there. So for teasing, the girl should be wearing something, like open or something, dress should be like, there should be no V. So they will tease. So what they will do with the Muslim woman who is wearing V? So they call her cabbage. It is banned, it is closed. Cabbage. We cannot do anything here. So we call it gobi, band gobi. Gobi means either cabbage or cauliflower. So band gobi means closed cabbage only. So they call it cabbage. Don't do anything because they are not sure what is inside. So they will not go for teasing. So there are many drugs which interfere. There are many stages of thyroid hormone formation. So they can act at any stage. Same hypercalcemia can cause decreased formation. Vegetables can also interfere. So depending upon the etiology, there will be decreased synthesis of T4 and T3. Okay? It will lead to compulsory increase of TSH. This TSH will cause hyperplasia and hypertrophy of the follicles. Okay? So there is enlargement of the gland. So with enlargement, there are bigger, smaller follicles with hormone fluctuation which go on. So hyperplastic, colloid involution. Hyperplastic, colloid involution. More fibrosis. So ultimately the multiple nodules will form. This is the parenchymal piece. Then it is followed by colloid involution.
So this is the primary lesion. And then
Colloid involution. And followed by the long standing. Yeah, if you give the iodine, you can stop also. But sometimes it will progress. If the iodine or the cause is persistent. Which one? This?
Primary cause.
Yeah, this is the primary one. Concerned with the thyroid gland itself. There is lack of iodine, there is a genetic defect, you are eating something. So if it is related to the pituitary, that is different. Okay? So we will go here. This is, the primary hypothyroidism we are talking. So this is how it will be formed. And what you will find pathologically. Epidemiologically. So what epidemiologically, who will tell me what is endemic and what is sporadic?
Local age, local.
So, sporadic is not whole word. Okay, endemic, I will tell you. Exact definition only Dr. Altaf can tell you. Epidemic, endemic. Pandemic means involving many continents of the world. Pandemic. Okay. Epidemic involving large populations. Endemic means in a population which is involving many people. Okay, more than 10 people you can say. Sporadic means one case here, one case there, one case there. Only some cases are. Okay, this is sporadic. So sporadic can occur due to ingestion of nitrogenous substance. In a population, few people will eat nitrogenous substance, or enzyme defects will not occur in all the persons. Okay, so this is sporadic. Endemic, when iodine is deficient. So mostly the population will require iodine. Suppose in Himalayas, mountainous areas of the world. So nowadays there also iodinated salt is there. But previously they used to take the salt which was not iodinated. So what will happen? Iodine deficiency was there, and they used to have problems, enlargement of the thyroid. So it was common in the Himalayas, Himalayan mountains, mountainous regions. So iodine deficiency again, decreased T3, T4, increased TSH, leading to hyperplasia of the acid.
But it's not necessarily comes with the growth. What? Hyperplasia not necessarily comes with the growth. You will find a case of hyperplasia without growth. Right? Okay. Yeah.
How? If you ask such question, we can take these questions at the end. Okay? Because if it is related here, it is easier to answer. But if go beyond the topic, then it will be difficult. We can discuss this at the end of the lecture. You can write it down. Then diffuse colloid goiter, you have two stages. One is the hyperplastic, and the second is the colloid involution. You will find diffuse, soft, symmetric enlargement. Mostly these patients are neoplastic. So what you will find? Goiter enlargement will lead to normal T3, T4. So T3, T4 will be normal because the thyroid gland has enlarged to compensate for the hormones. So mostly diffuse patients will be euthyroid. They will be having normal quantities of thyroid gland because the gland is normal size. So it cannot compensate. So it increases in size, forms more hormone. So T3, T4 comes back to normal. What happens in multinodular colloid goiter? Recurrent episodes of stimulation and involution. Okay, so multinodularity is produced. Lobulated, asymmetric, firm enlargement, acinine are variable. You can find hypoplastic areas, cystic and colloid areas. Stromal hemorrhage, stars, cysts and calcification. And when the gland is enlarged, it can have mass effects. It can compress the trachea, can compress the esophagus. What will happen if the esophagus is compressed? There will be dysphagia. Okay. And if the trachea is compressed, what will happen? Difficulty in breathing, like stridor. You will find a big noise coming here. So these things can happen, and sometimes some of the nodules can become toxic and secrete more hormone, leading to hyperthyroidism. So diffusely enlarged gland, this one, okay, somewhat nodular. So now the nodularity is starting to appear. When it is later stage, you will find big nodules. This is diffusely enlarged, but little nodules you can see. So it is starting to appear nodular. So these are all stages. Parent cavities, colloid followed by multinodular. Clear? So follicles will be big there, irregularly enlarged with flattened LVC. And this is the multinodular. Fine. Yeah. Yeah, mostly even the multinodular goiters will not be having the toxicity, will not be having increased thyroid hormone. But some of the nodules can secrete increased quantities of hormone and it can be toxic. But again, some, not all.
Some of them will undergo hyperplasia to compensate.
Yeah.
Yeah. Some of them undergo.
You know what happens? I will tell you. There is one important thing. There are lymphoid proliferations. They turn into lymphomas. You have seen that in H. pylori infection of the stomach. There is lymphoid proliferation, okay? But it can turn into lymphoma. Why? When the cells are put under increased stress, they divide again and again. What will happen? New mutations. What cells can do if there is mutation? Suppose there is one division of the cell. One division of the cell, okay, mutation occurs. There is a resting period, there is repair, mutation is gone. But again, the cells divide, mutations appear. What will happen? There is no time for the repair. Some of the cells, the mutation will be carried on and it can become cancer. Same here. What will happen? Some of the cells, some of the nodules, hyperplasia, some of the nodules can become autonomous. They don't require TSH now. They can automatically form more hormones. So this is autonomous. This is the latest which I got from economics. You asked this question, so this is the answer. Some of the nodules become autonomous. They don't require any stimulation. They form increased hormones. So this is the toxicity. They can be hyperthyroid. Clinical features: area obstruction, dysphagia, and calcification. And sometimes they may mask the neoplastic disease also. You see a big underlying, there may be neoplasia also. But how much you will do the FNS? At how many places you will go? Isn't it? So you can miss a neoplastic disease also. And toxic or hyperfunctioning nodule can develop hyperthyroidism or lumbar syndrome. You will find no ophthalmologic signs. Because to differentiate a toxic nodule from Graves' disease, how you will differentiate? In Graves, you will find protruding eyeballs, but here you will not find out. This is how toxic nodule. So you can see your face. No. So you will find. You will reach the conclusion. Now comes the Graves' disease. It is an organ-specific autoimmune disease of the thyroid. Organ-specific. What happens in the Graves' disease? There are three things. One is thyrotoxicosis. There is hypermetabolic state due to increased T3 and T4. This is basically the hyperplasia and leading to hyperfunctioning, diffuse enlargement of the thyroid gland. And there are two more signs. One is infiltrative ophthalmopathy, 40% of the cases, and very less cases you can find infiltrative dermopathy. Okay, there is pre-tibial myxedema. Here, it is present in minority of the cases. In front of this is called shin, in front of the tibia. There is thickening and hyperpigmentation. Thickening, induration, and hyperpigmentation. So this is called pre-tibial myxedema. Epidemiology, 20 to 40 years. It means at a younger age, women more, almost all the thyroid, diseases are more in women. 7:1. There is a genetic predisposition also. Association with HLA-DA and DR3. Yeah, 40%. Yeah, eye science. Infiltrating ophthalmopathy. Why it is called infiltrating? Because there is infiltration of the eye with the T cells. Okay, with the antibodies. So we will come to that inshallah. What is the pathogenesis? Previously, the pathogenesis, nowadays, most of the things, when we come to the pathogenesis, we see most of the things. Previously, we used to say autoantibody. Now we say there is something wrong with the helper T cells. Many diseases, the pathogenesis is changing. They say there is something wrong with the. So here also, breakdown in the helper T cell tolerance. So there is a breakdown in the tolerance of the T cells, which will lead to the production. Because helper cells. What is the function of the helper cell? Yeah. Helper cell, helper T cell. Not the production. Which cell forms the antibodies? Which cell forms the antibodies? Which lymphocyte? B lymphocyte. Yeah. So B lymphocyte forms the antibodies. Clear? What is the role of the T cell then? It helps. That is why it is known as helper T cell. Okay? It sends the signal to the B cell to form the antibodies. Sends the signals. These signals are important. If these signals are not there, it will not form. Okay? So now what happens? There is breakdown in the T helper cell tolerance. Antibodies are formed against the thyroid tissue. They may be formed against the receptor, against the thyroid peroxisomes, against the thyroid globule. Yeah. How much?
They are against TSH.
Yeah, this is the pathogenesis. We'll come to that. We'll come to everything I know this thing will raise a question, this thing will raise a question, I will tell you how. So antibodies against the receptor, against the paroxysm, against the thyroid. What are the anti-TSH receptor antibodies? Your answer. Thyroid stimulating. Yeah. If no, the antibody is called thyroid stimulating. What it means? It binds to the TSH receptor and has the same effect as the thyroxine. Same effect. So what it will cause? Hyperplasia. Isn't it? No. It will lead to increased thyroid hormone formation. Thyroid stimulating. Instead of the thyroxine, this antibody is binding to the cell, but causing increased formation of the hormone. Okay? Or increased effects of the thyroxine. Second is thyroid growth stimulating immunoglobulin. It binds to the TSH receptor, causes hyperplasia of the thyroid gland. Where? Hyperplasia. Another is TSH binding inhibitor. So it binds but inhibits the function. But here what happens? This is the reason why some people with Graves' disease have in between the episodes of hypothyroidism also. Because of inhibiting antibodies. So TSH receptor antibodies are three types. Either they will bind the receptor and cause the same effects as the thyroxine, or they will stimulate the thyroid hormone growth also, or they can inhibit also. But these inhibiting antibodies are very less. But they account for the episodes of hypothyroidism which can occur in Graves' disease. Okay. So these two antibodies, hyperthyroidism, this can cause hypothyroidism, and it can be seen in Graves' disease. So this is the pathogenesis. Got it now?
Yeah.
So it is binding and causing the same effects as the thyroxine. Now breakdown in, we will show you this. What happens? This is a normal T cell. This is saying to the B cell, please, this is my thyroid tissue. Please don't form antibodies against this. But who is controlling this T cell? Who is controlling? There are suppressor T cells. You know, T cells, cytotoxic cells, helper cells, suppressor cells. So T cell is there, it is going to help the B cell. But it has to be controlled. Who is controlling? The suppressor T cell. No, if there is something wrong with the suppressor T cell, genetics, something wrong with these T cells, so it was suppressing it. No, it will not suppress. So what will happen? Helper T cell will say, oh, B cell form the antibody. Whether it is your own tissue, no problem. Form. Because it is not being regulated. This was a policeman here. As you said, policeman. Policeman was trying, oh, no signals. So stopping it. No, the policeman is gone. Suppressor T cell gone. So T helper said, yes, I will do now. No problem. That's the B cell. Form antibodies. It forms antibodies. Antibodies go to the thyroid gland. Stimulate it. So there is hyperplasia. Increase T3, T4. Okay? So it will go to the pituitary, cause compensatory decrease in the TSH. And some of these antibodies also go to the retroorbital tissue. Here, retroorbital. So there also they say there are TSH receptors in the retroorbital, especially on the fibroblasts. So this is latest from the Robbins. On the fibroblasts there are retroorbital TSH receptors. If these antibodies they bind to those receptors, there is fibroblastic proliferation. And these fibroblasts form more of mucopolysaccharides, like glycosaminoglycans, hyaluronic acid. So increased quantity. So these antibodies go to the thyroid, go to the retroorbital tissue, okay, bind to the fibroblasts. T cells also reach there, and they secrete more cytokines. More mucopolysaccharides are formed, and they will lead to edema behind the eyeball. When there is edema, inflammation behind the eyeball will come out. Okay. This is the pathogenesis. So eye muscle antibodies also lead to. So in the eye, you will have more inflammatory cells, more T cells, more antibodies. All will lead to more edema. Okay, and there will be protrusion of the eye. This is the reason for the ophthalmological science. Yes. these are same. These you know, lipo, amino, lichens includes all the mucopolysaccharides, hyaluronic acid and other things which are found. Chloride and sulfate is here. These are basically mucopolysaccharides present in the connective tissue. So this is the pathogenesis. Anybody wants to ask any question? This class requires 2 lectures. Believe me, have a better understanding. Because you are covering all the thyroid is a very common thing. It has so many diseases, and how much you will contract it, and how much. So you require at least 2 hours if you want to explain them fully. Thyroiditis can be covered in 1 lecture. Other diseases you can put in another lecture. Graves' disease is clear.
About the inhibitor, how it will affect?
Yeah, inhibitor will cause decreased formation of the thyroid hormones, and sometimes the Graves patient will have hypothyroidism. So when these antibodies are more, there are different types of antibodies. One of them is thyroid inhibitor, but the quantity of this is very low. So it can lead sometimes if the quantity of these antibodies is more, it will lead to decrease in the thyroid hormone.
Then how we can say it's a Graves' disease?
Yeah. Graves' disease, because majority of the antibodies are others. But this type is also found. So in Graves' disease, mostly it is hypothyroidism, but typically there can be active source of hypothyroidism. So the doctors, the scientists look for why in Graves' disease there is hypothyroidism. They search and find this antibody. They say when this antibody is more, it can lead to decrease in the thyroid hormone. Clear?
What's the difference between this hypothyroidism and Graves' disease and other hypothyroidism?
Difference is obvious. This is occurring in Graves' disease.
We
It's
can
only
say
a
it's a
part.
Graves' disease.
The Graves' disease will already be diagnosed. It has already been diagnosed. It will occur in between. Some episodes in between. Got it? So that is already diagnosed. Proptosis is already there. Exophthalmos is already there. Hypermetabolic state is already there. But in between hypo. So why? Because of the thyroid inhibitor immunoglobulin. So this is a pathogenesis. Have a look. Wake up, say, wake up. So autoantibodies against the TSH receptor, immunoglobulins, they will also lead to eye symptoms. They will go to the eye. They will bind to the TSH receptors in the thyroid gland, stimulate the release of the thyroid hormone, increase T4, T3 and thyroid hypoplasia. It will lead to increased sympathetic stimulation, causes white staining phase also, and hormone release increases the deposition of mucopolysaccharides also in the connective tissue, and it will lead to pre-tibial myxedema, dermatopathy and deposition behind the eye. This is the whole pathogenesis. Clear? So in nutshell, you have the thyroid antibodies which will cause. But the cause behind the antibodies is the breakdown in the T cell immunity. Breakdown. Basic cause. Morphology, as we discussed. Enlarged form leafy red appearance. You will find hyperplasia of the acinar epithelium and it will grow, but the papillae will not have the fibrovascular pores. Local accumulation of lymphocytes can be there. So this is the appearance. Last time we discussed. Clinical features, enlargement of the thyroid gland will be there. Gluey will be there. So these blood flow through the gland will produce some sound. Okay? Listen to it by the mind with this stethoscope. Ophthalmopathy, you will have wide staining gaze, protrusion of the eyeball, exophthalmos, intact will be there, weak extraocular muscles, and because the eyeball remains protruded and open, it can lead to corneal injury. Dermatopathy is pre-tibial myxedema, you will have thickening and hyperpigmentation on the shin. Diagnosis, how you will diagnose? Look at it. T3, T4 will be increased and TSH will be decreased. Along with this, the important investigation is radioactive iodine. If you give radioactive iodine, there will be increased uptake because the thyroid gland is hyperfunctional here. It is functioning heavily. So it will take up the iodine. And when you perform the X-ray, you will see there is, increased uptake. It is labeled basically. Radioactive iodine is labeled, and you can see the increased uptake inside the gland. So this is Graves' disease. Now coming to thyroiditis. We'll finish in 5 or 10 minutes at the most. So what is thyroiditis? You can have acute like infections. This is painful. Subacute granulomatous, again because of viral infection, painful. Hashimoto and subacute lymphocytic, they are painless. Then renal thyroiditis, discussed at that. Palpation thyroiditis is when a doctor like you, like student doctor or internship, he wants to study. So he will go on palpating. I want to see. And patient will, he is having nothing, but he will have no palpation because of the palpation. So there is damage to that. So there will be vigorous palpation, destruction, and granulomatous inflammation with normal TF. Okay. So Hashimoto's, we'll finish it quickly. This is also known as autoimmune or chronic lymphocytic thyroiditis. Yesterday we discussed. 20:1 female male. Older age, 45 to 60. At an older age than the Graves' disease. Painless enlargement will be there. Remember one thing. Although Hashimoto causes hypothyroidism, it causes hypo, but initially it can cause hashitoxicosis or hyperthyroidism. Why? So there is transient hyperthyroidism initially, hashitoxicosis, followed by hypothyroidism, and it is the commonest cause of hypothyroidism in iodine sufficient areas. There is common cause is iodine deficiency, but the places where iodine is sufficient, you will have the common cause as Hashimoto. The people who are taking iodine also, but you find hypothyroidism. The commonest cause will be Hashimoto thyroiditis. So how this hyperthyroidism occurs? Because when the follicles are destroyed, initially they will release the thyroxine. So there will be initially hyperthyroidism because of destruction of the follicles. The colloid and these thyroid are being only initially. Then possible complication is the lymphoma because it is characterized by autoimmune proliferation of the lymphocytes. Lymphocytes come and they go on dividing. When there is increased division, again, what will happen? There are chances of mutation and it can turn into lymphoma. This is the reason. So autoimmune destruction of the thyroid tissue. Again, the important thing here also, CD4 helper cell. Something wrong with the helper cells. And autoantibodies will be produced, genetic factor DR3, DR5, and with it is associated with all other autoimmune diseases. I will tell you the pathogenesis. So beautiful diagram. In one diagram, everything explained. Thyroid epithelium contains the thyroid antigens. So there is T cell sensitization in the thyroid antigens. Okay? So T cell, helper T cell, it becomes sensitized because of autoimmunity, because of something wrong, genetics. It doesn't recognize thyroid as a self antigen. Somehow it says it may be a foreign antigen and starts stimulating the plasma cells or B cells to form the antibodies. Okay, these antibodies they attach to the thyroid epithelium. Okay, and these antibodies are recognized by NK cell. They destroy the epithelium. So this is called antibody dependent cell mediated cytotoxicity. So it is dependent. Antibody cannot kill the cell directly. It has to be killed by some other cell. So it is killed by the NK cell. So this helper cell causes more antibodies and it will lead to destruction to the NK cell. It also causes, secretes interferon gamma, which activates the macrophages, which destroy the epithelium. This is the second. Third, this also stimulates the CD8 plus cytotoxic cells, which kill the thyroid epithelium. So something wrong with the helper T cell, which leads to activation of the macrophage, cytotoxic cells and NK cells, which destroy the thyroid epithelium. This is the pathogen.